Sorry, I don't more questions.
It's okay. The thing is, every standardized patient, I told them to add their personality into their role. So everyone experience will be different. The information will be the same, but everyone will be different. So the next time if you see a different standardized patients, it will be a different experience. So nothing will be the same. I hope everyone enjoy talking to them in English because we talk in Vietnamese all the time. So let's hope 30 minutes talking in English every 2 weeks will help you. Right. So any questions so far? Thương, am I host now so I can share my screen?
Yes, you're welcome.
Okay. So here's my screen. Let me move this out of the way. So because everyone asked a bunches of questions, so let's standardize what patient has first before we move to what everyone is eager to learn about, which is the lab result. I know everyone will see that. So, but let's go over what the patient tell us first. Okay. So this is the patient profile. Again, we got 65 years old, female. Well, this time it's going to be female, but don't worry if your patient is male, it's okay. Just for profiling.
Pardon, and Leon, can you like make a full screen? That's better for everyone.
Oh, full screen? Okay, I'm sorry. Where do I do that? Okay, right
yes.
here. Sorry, my technology skill is low.
Low tech.
Yeah, I'm really low tech. So yeah, come in with clinic with the cheap complaints of I feel weak all the time, and as she mentioned, it's about 6 months ago. It starts suddenly at work when she was teaching. Similar problem the last few years, but none had happened really about 6 months ago. Was able to walk around the house multiple times, but now she's unable because of fatigue. So I hope everyone got a similar, maybe not the same, but very similar history as what I collected. By the way, this is the real patient cases, so we'll see. It's gonna be a fun case. What triggered her fatigue is when she stand up suddenly. Resting make it feel better. If you ask her about how bad is the fatigue, she'll probably say something like very bad. She feel dizzy and may not walk properly. Timing has happened about 1 to 2 times per week. Until about 3 months ago, and now it's more often, 3-4 times a week. Every episode lasts about 10 to 15 minutes until she rests. No injury or trauma here, and she says she also has some pain in her mouth. Does anybody get pain in her mouth as a history? Okay, I assume everybody asked that, or if your patient tell you about that. Okay, her past medical history, I wonder if anyone asked this. She have hypertension. And she currently on amlodipine 10 milligrams once a day. Her allergies, some people in the main room being asked about allergies, but her allergies is penicillin. And when you ask her what kind of reaction, when she take penicillin, she will say she have a rash. Okay, so make sure when you ask people about allergies, ask them what kind of reaction it is. Some may say, oh, I pass out when I take this medication, or I have a severe rash. Okay, but make sure to ask what reaction it is. It's good to ask about surgery, but she have no surgery and no hospitalization, so everyone follows so far. If I talk too fast, please stop me. It's okay to stop me halfway. Just raise your hand and stop me, that's fine. Okay, so her social history is she's smoking 2 packs a day for 20 years. So if we time this together, it's going to be 40 packs a year. She doesn't drink any alcohol, use any drugs. She married, happy at home, and see a science college professor if you ask about her occupations. Family history, this is important. Father died of colon cancer. Mother dies from leukemia. She have no siblings, and she only have 1 daughter and healthy. Okay. Review her system. She report having no fever, weight loss, weight gain, night sweat, no runny nose, ear pain. Basically, it's mostly negative. Okay, does anybody ask about physical exam? Anybody ask to listen to patient heart and lungs and okay? All right, I assume everybody do, because if you ask about physical exam, tell the patient to tuck out their tongues. They probably have some glossitis going on. Okay. If you ask to look at patient fingers, they happily have some colonychia or concave up of the fingers, or patient may curious and show you that. Okay. And patient vital sign, blood pressure is 168 in clinic today. Heart rate 68, respiratory rate 15, temperature 98.6, and O2 saturation is 98% at room air. Now, has anybody asked if this blood pressure is like that all the time, or it's just like that today? So if you ask that, patient probably say, oh, it's just today, but her blood pressure has been controlled. Okay. Any questions so far? So up to this point, what do you think patient has before you order some stuff? SB can talk to, no worry. Anybody have any idea, vague idea of what in your head patient might have, and what direction are we heading on with all the information so far? Nobody, nobody want to say anything.
I think so.
Okay, I think we just forget, one size, conjunctival pallor.
Say what?
I think we just forget conjunctival pallor, one side.
Yes. Well, yeah, that was part of the physical exam. I forgot. It's also have conjunctival pallor. Can you type it in there? Okay. If you ask about color of urine and stool, patient probably say it's normal. They don't notice any difference. So we did collect some basic lab of the patients, and I will review it to you now. Because we know every patient come in with fatigue. The common thing we do is getting CBC. So this is the patient CBC.
No, sorry. I think like it depends on like what you guys want to take the lab test for this patient. What you want? What what result you want of the lab test?
So I already go ahead and take a CBC for you guys. Is there any lab that you guys want to do?
For the lab test.
So this is your patient CBC.
So anyone in here can help me to like figure out what abnormal for this CBC result.
Well, I think the result is microcytic anemia.
So what makes you think that's a microcytic anemia?
Okay, I think the abnormal thing here is the red blood count. It is less than normal, and we only focus on hemoglobin. It's lesser, and the MCV. I'm sorry. It's microcytic anemia. Sorry, I just confused. Yeah.
This increase MCV, right? So we had we just like take note about result. We have like decrease red blood cell, decrease hemoglobin, and increase MCV. Just take a note at this, because we can not make any diagnosis in here if you need further tests. It's still controversial.
I think Ms. Nguyen 1996 just raised her hand or something.
Sorry?
Ms. Nguyen 1996, I think she has a question or something, because I think she just raised her hand.
what me, Yuying, right? What you want to ask? What the test you want?
No. I just think you want to ask questions and I raise hand to answer you.
All right, go ahead. So
I see the same things with the last person. I think is the macrocytic anemia.
macrocytic anemia. Yep.
Yeah.
So you think patient have macrocytic anemia?
Yeah.
Okay.
Because I have the same idea with previous person.
Who said it's a microcytic or macrocytic? Sorry, I maybe heard
Actually,
something
I
wrong.
just confused at the first
Macrocytic.
Yeah.
Macrocytic anemia.
Well, actually, yeah, in my opinion, I just confused at the first place. But the answer, my opinion, the patient may suffer from macrocytic anemia.
Macrocytic anemia.
Good,
Okay.
good point. Macrocytic anemia.
Sorry, macrocytic. Yep.
Okay. Yeah, patient definitely have some anemia going on. Well, 4.68 to 4.70 is not really that bad, but the hemoglobin is low for sure. Yeah, but the MCV is definitely high and it's very concerned. So is there any lab that anybody want to get, or this is good for you guys? Should we get a chest x-ray in this patient? Why you think we need a chest x-ray? I saw you shake your head.
Okay. Well, I think based on the age of the patient, she is 65, and I think this is the age that we must to rule out some lung problem like cancer. But in this patient, I think we need to do some tests about screening tests about colon cancer because his father died of colon cancer.
Well, good job. That's a good recommendation, but it doesn't really relate it to patient complaint. But it's a good thing to know. It may or may not. If patient have anemia, you may want to do a colon cancer. So, does anybody want to do a complete metabolic panel by any chance, like CBC, CMP? We already do CBC, so you guys want to do CMP? I go ahead and do it for you guys too, because I'm a good preceptor. So this is the CMP in case if anyone want to look at, and it's normal. So at this point, what's your differential, guys? What's your differential? What's your differential diagnosis? And what should we do for the patients?
Okay, with with the symptom and the sign and the past medical history from the patient, the diagnosis that I think most is iron deficiency anemia. So I think we just repeat the complete blood count in the next day or the next 2 days, to examine about the hemoglobin and what kind of the anemia.
Okay, good. Anything else on your differentials? So we got Hung say that it may be iron deficiency anemia.
Do you think that the patient can have could have like a thalassemia?
Thalassemia?
Oh, so I want to ask if thalassemia is just what type of anemia patient can have if his patient have thalassemia?
Is it like alpha thalassemia? Is that one of it might be it?
So Thalassemia could be good. Yeah, I won't say your differential wrong, but patients should have more history on that one. But let's just keep it in mind because who knows what might happen. So Ang chat in the chat, he say patient have iron deficiency, anemia, parasites, infection, GI bleed, and maybe leukemia. That's a really good differential. It's cover almost everything that we possibly can, but it still doesn't explain the high MCV. Colon cancer definitely can explain high MCV. Definitely is correlated. So that's a good point. So let's go to the differential. So we know patients have anemia, but we don't know what type. So we know the MCV reviewed as maybe microcytic, but some physical exam findings suggest that patient may have iron deficiency anemia, which is microcytic. And I think Ang say thalassemia. Thalassemia, I think, is also either microcytic or normocytic. GI bleed can definitely cause some hemolytic anemia going on. That's definitely a case. Patients are also on amlodipine. Amlodipine, as you know, one of the side effects can cause dizziness as well. So that may be the case. Patient blood pressure may drop today, and hypotension, and definitely underlying malignancy. Yes, symptom of clausitis and spoon nail may suggest iron deficiency anemia, but the MCV is microcytic. So that's a good point. As you all commonly learn that those symptoms suggest iron deficiency anemia, but did you know that what's the patient occupation, guys? Science college professor. So as a science college professor, do you know sometimes patients work in the labs and being exposed to chemical? Have you think about that? So another cause of spoon nails is also occupational exposure. Okay, so and the patient is science professor, so he or she may have some cause of that. So we don't really know what is the real anemia here, either iron deficiency or MCV, but Hung will bring up the good point. The current recommendation is you should repeat the CBC in this patient for sure to make sure that the anemia is real and is not superficial. Okay, so we should definitely repeat the CBC the next day. Okay, so that's a good point. But that's a good job, guys, for bringing up all the differential diagnosis. Thương, you have anything you want to add?
Okay, can I ask question about the patient's mood?
Yes.
Anemia, or the symptoms may be the psychiatric disorder may be the cause of the fatigue. So I want to know more about the patient's mood recently. Do they feel sad? Do you feel happy, or do you have some stressful things in their job, or something like that?
That's a good point to ask. Okay, so patient mood may definitely make she feel tired, even though she say happy at home, but you still want to ask her about, okay, if the patient feel okay, feel stressed doing work or something. So mood is definitely can be on your differential. Your differential can be longer than 3, so we're gonna add mood disorder on that if you want. But definitely mood can be a factor involved in this case. Okay, so I think the most confusing thing that people have question with this case is the physical finding of iron deficiency anemia and the lab finding of macrocytic anemia. So when the patient come in to me on my service in the hospital, I was so confused about this too. But you know that in real life, patients have multiple problems. They're not just one. Clausitis is not really specific for iron deficiency anemia, but we always think it is. But the guideline that the current research says may not really be specific for just one type of anemia. So you always have to keep your mind open about what the patient might have. And of course, she's smoker, so we definitely want to do a chest x-ray or a CT scan of her lungs, her chest, and also because she may at risk for colon cancer due to her father have a colon cancer, so definitely recommend colonoscopy. So to sum up, what we're going to do for this patient is we're going to repeat the CBC to make sure that the anemia is real and is not superficial. Also to find out if it's really iron deficiency anemia or not. We're going to recommend follow after the CBC, and definitely abdominal CT, chest CT, and definitely to rule out GI bleeding, you want to do an EGD and colonoscopy as well. So that's what I'm going to work patient up. I think we cover almost all our bases so we don't get sued with something wrong with the patients. Is there any other workup that you guys want to do specifically? Do you want to test for parasite? Because earlier someone mentioned parasite. What kind of parasite is that? I'm curious. There's one parasite that may cause anemia, but I don't know. You guys remember the name? I think it's called Necator americanus. Some kind of hookworm.
Spongitis. I forgot the spongitis.
Yeah, so if patient really have parasites, then it's easy. Just give some anti-parasitic medication and discharge. Necatorius pinworm. Or hookworm. Pinworm cause?
No, I don't think pinworm.
I don't think pinworm cause anemia.
Anemia, yeah, just like make pruritus in the anus.
I think it's hookworm.
Hookworm, yeah, can be.
Nguyen, you raise your hand. Is there anything you want to add?
Yeah, it's a mistake on my screen. My gosh.
So I understand that everyone may not satisfy with what they think and want the answer right away, but please be mindful that patient in real life may have multitude problem and not always straight on paper. Because what we learn is what we learn, and then when we go out in the real world, we see crazy things. And sometimes patient might just have iron deficiency anemia along with macrocytic anemia. You know,
So
I
do you
have a couple.
Do you have the confirmed diagnosis for this case, Leo?
We don't, because on my patient chart, all my preceptor lists were just anemia, unspecified cause.
Oh,
And then we just follow up closely with all the preventive care because we couldn't really find what's going on. She could. Hypothyroidism certainly cause some fatigue, but that means that we need to add that to your differential, and we need to get the TSH and T3, T4, which that's a good point because everybody forgot. Good point. Hypothyroidism definitely can cause it.
Yes, but I think it's patient. The hypothyroidism, it is less. I think it is less likely
It's
because
definitely less likely.
it has hypertension. So
Yes.
I think the patient, the less diagnosis is hypothyroidism because the
Yes.
patient has hypertension.
Yeah, that's a good point. It's less likely, but it's also good to put up there. You never know what's gonna happen. Okay. All right. I have a couple of clinical pearl I want you guys to take away from this case. It's from what I read during my rotation with this patient. She doesn't have iron study, so we definitely want to do that. That's why I say we do a CBC, and we may want to do iron study to rule out iron deficiency anemia. That's a good point. Iron study.
good point. Yeah.
I was waiting for someone say iron study. Someone say yes. Iron study to rule out iron deficiency anemia, guys.
Yeah, that's right.
So here's a couple clinical per that we collect. So we want to repeat the CBC, like I say, to confirm if the macrocytic is real and not artificial. Also, Brodsky say that macrocytosis with mild or no anemia usually have no abnormalities, okay? But there may be something suggesting the myelodysplastic syndrome, okay? So current recommendation is follow-up. We don't do anything for that. There's no screening test for that. And as Hương mentioned, well, not yet. Sorry, that's not the slide yet. Most adult age higher than 65 usually have higher than average MCV. So usually we don't do any extensive evaluation if the patient MCV is between 96 to 100, but our patient MCV is more than 110, so we definitely want to work her up with a little bit. So definitely we want to repeat CBC. Colonokia, as you guys all learned in school, is associated with chronic iron deficiency anemia, but it can also expose, if the patient is exposed to something called petroleum-based solvents, which is very common in labs, in organic chemistry labs and chemistry lab. You occasionally use this thing, so who knows what the patient might have been exposed. She doesn't really tell us when she comes into the hospital that she's a college professor. It just happened that her son or her daughter tell us that, oh, my mom work in the college and she do research, so now she in the hospital, she cannot do research. So we asked her about that, and she said, oh, she's a science college professor. I said, okay, yeah. So I go ahead and read about it, and well, definitely maybe she's been exposed to this one chronically, that she may have some physical exam finding that's suggested. But the guideline is we have to rule out iron deficiency anemia by doing an iron study. So good job on iron study, guys. So a couple of things about recommendations and preventive things. So patient with history of smoking 55 to 80 may require one-time chest CT to check for abdominal aortic aneurysm with ultrasound as well in males between 65 and 75, and annually CT, I think, for lung cancer screening. And we definitely want to suggest the patient, hey, go ahead and get a colonoscopy, because she in that age group and she have a family history. Okay, so patient don't really like to do colonoscopy, by the way. Every time I tell that to patient, they just say, but yeah, it's a good recommendation. Okay, so far good job everyone on finding out and have a good workup with the patients. So I hope it's answered most of your question. Let's see, someone in chat. No, you guys speak really good English. Your SP told me that everyone have a really good English. So any question left? Any lingering question, suggestion that we can make this better? Thương, you want to say something?
I thought everyone here, when they look at the patient have fatigue like that, I think they also looking for about some kind of the classification of the anemia, like macrocytic or microcytic or normocytic anemia. So actually, I want to give you guys about some kind of information on how we approach the anemia case. But I don't know that's necessary. Like I feel like you guys are looking for a lot about this, according the way you ask about the patient, and they order the test, and you can make the differential diagnosis. So
everybody in here is a good doctor, because I think
that's
everything
really right. It's excellent. Wow, it makes me feel like I feel shy when I can give the lecture. But so you guys feel like we need to do more about this? Like you want to learn, you want to give some tips or some information about how to approach the case with the anemia like that?
Sorry for interruption, but we have a question in the box chat.
So bone marrow biopsy, that's a good idea, but it's a little bit more invasive, and I don't think it's okay to do it right now. We might want to run a couple of lab tests first. We may want something called CBC with differential. So the CBC with differential will give you an amount of cells that the patient have, eosinophil, neutrophil, stuff like that. And if there's warrant something concerning about leukemia, then yeah, we want to do a bone marrow biopsy. Yeah. Yeah, as Hoon say, that's a really good point. See, everyone learns something new. Like one asks something, then there's someone answering with the new information that we can learn. See, I want this section to be like exchange of information where everybody learn from each other. Okay, it's not one-sided like me giving a presentation. So, and you guys already have plenty of English practicing with your SB. So, any other question, concerns? I mean, you can give everyone the flow chart for anemia, I guess, since we talk about anemia.
Oh, okay. It's very quickly preparation.
I mean, you can post it later. It doesn't have to be.
Yeah. So I'll give you quickly about can stop your share
Yes,
screen?
yes, go ahead. I'll stop.
One second. Yes.
So guys, if you see this case in the hospital, make sure you impress your attending.
Impress. I guess so. So let's start with this how the way you approach the case is a little bit technical here. So I give you guys about some like the way you approach the case with the anemia. So look at when we see about a patient with some kind of symptoms, suggest the patient have like anemia, the first thing we will do is to do CBC, like Mr. Leon talk about this. And when after we have the result of CBC, most of the patient with the anemia, they will have decreased hemoglobin, right? So that's the first point. And next step, we will read further about the MCV. So with the patient who have the MCV decrease like that, we suspect patient can have microcytotic anemia. And after that, we'll do the iron studies, and we will recognize what type the anemia patient, like the subclassification, like iron deficiency anemia or anemia of the chronic disease, or thalassemia or sideroblastic anemia. So it depends on the lab test we receive after that, and they have the some kind of the something increase, something decrease here. So for further tests, we will do and recognize what type the specific anemia, microcytic anemia. Alright, so I want to help you guys how to differentiate between that. And because when we do the iron study, we will have some kind of the parameter you need to pay attention. First of all, this is TIBC. So what I mean of TIBC, you guys? The sideroblastic anemia means like this is some problem related to like this make the hem is mean like one of the component of the red blood cell. Hem is mean HEM. So there are plastic anemias like this, they don't have enough iron when they make the hem. We call like in Vietnamese they call like thiếu máu nguyên màu sắc. Yeah, correct. So I want to ask about the TIBC. What the meaning of TIBC according you understand? Anyone here know about the TIBC? I know you guys know about that. No, forget this. This is wrong. Don't think about this. T is not
I think Ang answered.
Oh yes, so blood capacity to buy iron with the transferring kind of like nearly correct. So this is with the abbreviation with the total iron by capacity, right? So they divide into three types the parameter here. This is TIBC, this is the iron and the ferritin. So we know this the TIBC means the blood capacity to buy iron with the transferring, and the iron, this means the iron, the component of iron in the blood, this means the level of the iron. And then last one is the ferritin here. So when we look at the when we look at the three changing of the parameter here with the increase of TIBC has means available storage of the iron. So we have like we see that increase TIBC and decrease iron here and decrease the ferritin. So what you see here, it means like when the available storage iron, like this the increase mean like it's become like empty here, right? So it means have the amount of the iron go somewhere. It means we decrease iron in our blood, and that's also make the ferritin. Being ferritin is mean carry the iron in the. This become like stock. This cannot increase as well. So you see this have more empty here. It means like patient have iron deficiency anemia. So that's the changing of the parameter with the iron deficiency anemia. I want to go with the next picture. It's also like have the same thing, but you see now it's different. You look at the TIBC and you see this decrease. So that's they have three like parameter here, TIBC and iron and the ferritin. So now the ferritin is an increase. It means like the iron in the store. You see that's the become like this this green color become like increase. So it means like this ferritin is the increase and the iron is the blood is decrease here. So what you can think in your mind what happened. So according to the changing in the parameter of iron study here. So what you can explain for that? What happened here? So why this can make like this is anemia with of the chronic disease. So what happened with chronic disease and make changing those of the component here? Who wanna explain for that? They said like they have this connection between the blood and the iron store, but the iron absorption is intact.
So I think technically patient iron absorption in the body is doing fine, but some chronic disease is preventing patient from taking irons to their body. That's why the storage going up. I'm just answering your question.
Okay. Okay. Yeah, that's also the point. But according to about the mechanism of some chronic disease with the chronic inflammatory progression happen in there. So actually like for kind of inflammatory disease with the chronic situation happen and some kind of like we call this some bacteria or even like some we call like bacteria eat the red blood cell and they keep the iron in them. So they make the iron in total blood this become decrease. And like Mr. Leon said the ferritin also decrease because of the like sometimes this accumulate in our blood because this cannot how can I say like the three component here have this something affect its order. So the iron absorption this doesn't affect this still like still is going well. It means like the iron absorption can go with the many way belong to the intestinal like the lumen of intestinal they will have the iron absorption. They can absorb iron in many places, so it's still is going well. So, but for the connection between the blood and the iron store, this is decrease. So it means if you know about the chronic disease, the inflammatory progression can bring like keep the iron inside some like bacteria or some kind of as I know like that. So it's make the iron store decrease, and that's decrease TIBC, and this increase ferritin and also decrease iron. That's the make we think this anemia is of chronic disease. All right, so next with the another type of changing in parameter of iron store with the you see here. So when you look at here with the thalassemia, the iron stories mean are normal, but what happened with the everything is look normal. So what happened with the thalassemia?
Well, I think with thalassemia, the iron story, ferritin, and the iron in blood is normal, but there's something abnormal in the red blood cell. Actually, more details is in ham. In thalassemia, there's something abnormal in the protein in ham, so it makes the red blood cell erythrocyte. They they lack the functions to take oxygen to the tissue in the body, so it makes anemia. But the ferritin, the total iron in the body is normal.
That exactly mean here like the thalassemia they have like affect the hemoglobin. So this change in hemoglobin this affect the hemoglobin. So doesn't have any problem with the iron store here. So I agree with you. So let's next with the another disease here, sideroblastic. So sorry, sideroblastic. The sideroblastic here we also call this with normal TIBC, normal ferritin, but the iron increase. So now you see here something happen. Why this make like elevated iron despite the anemia with the small cells? Interesting. Who wanna have me to explain that?
So whenever I see iron increase in blood, I think of two possibilities. Their body doesn't take irons and make hemoglobin, so something's going on with the red blood cells, or they just take too much irons in their bodies, and it's another different kind of disease. So usually when I see iron increase in blood, that's what I think. I don't know about the lab test at that time yet, but that's what usually I think. Some structural things going on with the red blood cells that prevent them to use iron. So that's what I usually think about.
I agree your point, but in here how we need to think about a little bit about how we make the hemoglobin, and after that we make the hem. So for hemoglobin we make every hem we need to connect with the 4 iron, right? We call this a fair this should be like 2+, right? So every hemoglobin they need to take with the it's the hemoglobin take with 4 iron with the 2+, let's make hem. So for sideroblastic anemia with the hemoglobin have problem, so they cannot create hemoglobin as a deficiency with the hemoglobin, and they cannot make the hem. So for the what you understand from that, have a free iron go somewhere. They cannot connect with the hemoglobin because we didn't produce enough hemoglobin for our body. Because have the problem cannot like produce hemoglobin, so hemoglobin cannot connect with that. So still have some iron deficient like become free iron in our blood. So this bring iron become increase in our blood, but still have the function still normal with the TIBC or normal ferritin here. Even if we still have anemia, we have symptom anemia, we cannot, is our hemoglobin decrease, still have anemia, but like all the thing here is just like keep the parameter like that. Alright, so in here have something a little bit long, so I want to take a look at very fast. With the iron deficiency, we do some tests like that. We just explain the best test like we do by bone marrow biopsy, and the treatment we get the iron, and for further tests we can do colonoscopy to check some malignancy condition in the patient for anemia or chronic disease. So we have like the changing in the iron study like that. We also do bone marrow biopsy and treat with the, like it depends on disease, steroids. So steroids usually could give some autoimmune disease. For anemia and chronic disease, especially I with you guys like rheumatoid arthritis. So we will treat with steroid or corticosteroid. So with the, or we can try with the EPO, is mean erythropoietin. So thalassemia, we also have some the change in here, and we do the test with the, like I talked about this hemoglobin problem. So it depends on the type of the thalassemia, like minor or major. So we can give the treatment specifically, and that's it. For transfusion, we do the deferroxamine, seroblastic. Yeah, you see some kind of the cause can bring the seroblastic anemia. So the lab test we will see here, bone marrow, we see some ring seroblastic. Rings mean like half cycle, like that's in our red blood cell. So we give the B6 being like with the same with the cofactor, we bring the in the pathway create hemoglobin in our body, and we can look for cancer. So that's this also we call the pre-malignant condition in our body. Sorry, we still have the macrocytic, but like just have 5 slides left. So for macrocytic anemia, we have like also do the same. Come here, it's an increased MCV, macrocytic. Sorry, and we look in the blood smear. In the blood smear, we need to see about what increase about the as we call like polymononucleatic. So if we see like hypersegmentation, it means have 5 lobes, it means hypersegmentation. So we think that have megaloblastic, non-megaloblastic. So in our megaloblastic anemia, we have 2 types. This is folate and vitamin B12 deficiency. Folate means vitamin B9. Alright, so we check again the level of the folate. If folate increase or it's a folate decrease, folate increase, we maybe patient have the B12 deficiency, or with the folate decrease, patient have folate deficiency. So after that, we need to do the test. Is we call like methylmalonic acid. Sorry, methylmalonic acid. We have the name MMA here because we have like the pathway can change from like vitamin B12 and vitamin B9 by the way we use with the methylmalonic acid MMI here. So if changing like with the increased MMI, we make conclusion patient have a vitamin B12 deficiency with the normal MMI. So yeah, the make conclusion patient have a folate. That's very quickly. So the same here, we also do some kind of test with the, oh sorry, I did the wrong thing here. Sorry, have problems? I will update about it just like for I just you have the same with the macrocytic anemia. So let's go with the normal cytic anemia. We also have the same conclusion here with no change. And then we do some like haptoglobin, bilirubin, LDH, and retics count. It means like when you call reticular red blood cell, it means like this is a premature red blood cell. So if they have like that, may confirm maybe patient have acute blood loss. So just like give the blood transfusion. If like it's not like that. So it's maybe patient have hemolytic anemia. So we do this sickle cell disease. Can be spherocytosis autoimmune disease or like PNH. He is mean like paroxysmal nocturnal hematuria. Paroxysmal nocturnal hematuria is mean like tiểu máu kịch phát về đêm. Alright, so G6PD. So we have three, like 1, 2, 3, 4, 5 type disease here. Actually, it's a really complicated if you want to looking for further tests and make the diagnosis and even treatment here. So with the sickle cell disease, we need to do the hemoglobin electrophoresis, mean là điện di protein. And we also like check with the folate, iron, hydroxy. So it means like we get the treatment, hydroxyurea, intravenous fluid, oxygen anesthesia, exchange transfuse. With the spherocytosis, we do the osmotic fragility or splenectomy. It's also one of kind of the important treatment for the patient. With autoimmune disease, we do the COM test. With the like some kind of the COM test, the autoimmune disease will come to this positive, and we get the steroid. Autoimmune disease like what type? Can be like IVIG mean like intravenous immunoglobulin. This a transfusion give the patient splenectomy as well. For like paroxysmal nocturnal hematuria, we do the flow cytometry and we check some like what changing here. With the cytometry, we can do with some kind of antibody or even like some kind of like what we call that for the complement. Yeah, complement here. So C4, C5 kind of like that. And we get the steroid eculizumab. So we see like this also one type of treatment, like we call this a monoclonal therapy. The G6PD level is also checked with that, and with avoid trigger. For G6PD, we have some kind of with the medication or even like food have the oxidant component inside, like fababine or some kind of medication can treat G6PD. We make like oxidate the red blood cell membrane. So in here, let's just remind again, just a look at with the, I give you the first step and the best step. With the G6PD deficiency, we get this blood smear, we will see like hands, body, by cell, because like the we call the red blood cell membrane deficiency. With the best step with the GCPD level, it will be decreased and with after the attack and treatment avoid oxidant stress, as I told you. Hereditary spherocytosis here. We do this smear with the spherocyte, and also we have like better osmotic fragility, and the best way we do the splenectomy. For autoimmune hemolysis, like some kind of like IgM or IgG, we call the antibody, and we do like blood smear, we see like spherocyte as well. And do COM test, it usually is positive, and we get the steroid or IVIG splenectomy. Same here. So just remind again, and some kind of the patient will have the risk factor with that. Alright, so I think like it's a little bit long for you guys to keep in mind about this. Just like when I talk, I need to talk like enough something about I want to mention. So if you have any question, I feel like you need to read more about this first, and then I will get the slide post on the Facebook for you guys if you want to keep track again. And if you have any question, you can ask me. Don't worry about that. It's a lot. I know it's a lot. For this, I can make the presentation in 3 hours with the whole like across the anemia. All right. So thank you so much.
Thank you so much to the wonderful presentation.
It's a lot. Sorry, I don't think like
anemia is a big topic, of course.
Yeah, sorry. I think it's a lot of time for you guys.
There's no way we can talk about it in 3 hours.
Even
in 1 hour, can't even.
I just saw in 15 minutes. Yeah.
Yeah. So, well, she will try to post everything on the group for you guys to read more if you guys want to learn more about all this anemia. Okay, but I hope you guys have a good time. Sorry we take a little bit longer than usual. Next time we try to keep it within the time limit so everybody can go enjoy the Saturday night. But thank you for everyone to participate today. I enjoyed having you guys, and you guys been having a lot of good questions, and I hope you guys gaining something out of this. And hope to see you in 2 weeks.
So you guys have any question for that? Is it allowed, right? Sure, it's allowed. I want to have more time to explain for that, but I think like I don't have a time for this. I just guess you guys have. Yeah, it's a lot. Yeah, I agree.
Usually, you know what we do in real life when we're approaching anemia? Send it to hematologists.
Yes, I think like so when you will get like transfer the patient to the hematologist.
So for common problem, iron deficiency, anemia, B12 and stuff like that, we can manage on our own. But with anemia, chronic disease, and we definitely want to involve more specialists involved. For those higher up, like sideroblastic, thalassemia, we want hematologists involved. Yeah, anemia is a huge, we cannot manage it in patient by ourselves.
I agree with that. Just like it depends on the situation of patient. They are like some kind of disease, how we need to transfer the patient to like hematologist.
The hematologist will do all the workup of the hemolytic anemia. So we don't do that in the hospital, here at least I know. Because it's a tedious workup, it's a lot of workup.
So thank you so much for you guys joining us today, and I hope you can learn something or even like practice the speaking skill.
So the minimal goal is to have everyone practice the English skill, okay? But I hope everyone take out something from this presentation.
So see you guys into next week.
See you guys in 2 weeks. SB, see you next week.
No, SB stay with us.
Yeah, SB stay with us. Sorry. And don't forget to do your submission, the soap note, okay?